So we're going to change tact a little bit, continuing with programming, but talking now about troubleshooting. Now, various people throughout the afternoon have sort of given hints and suggestions as to some of the troubleshooting we might do. But I'm now going to try and delve in a little bit more detail into some of the common things you need to be aware of. I have to say it's very strange being up here today speaking now, because the last time I stood on this very stage speaking was actually my wedding, and so the audience is a little bit different, but nonetheless. So I think what we've seen is that HIS pacing is very feasible. In the overwhelming majority of cases, very quickly, you're going to map a HIS potential, you're going to easily be able to deploy a lead, you're going to get great pacing responses, and you'll have low thresholds during long-term follow-up. And then you can utilize this approach to deliver far better pacing responses than RV pacing. The problem is, sometimes there can be issues. Some of these issues can be programmed around, but unfortunately, some do need lead reintervention. You sometimes hear in terms of concerns, thresholds with HIS bundle pacing are too high. These higher thresholds can sometimes be caused if the lead tip is not deployed fully so that it penetrates through any fibrous insulation around the HIS bundle. And you can see what I mean here for those of you looking at this screen. This fibrous insulation, you want to make sure that your lead really gets right through to make sure that you've got reasonable thresholds. Now, I think it is fair to say that HIS capture thresholds are typically higher than RV thresholds. That being said, HIS capture thresholds that are more than 2 volts at 1 millisecond are only reported in approximately 10% of patients at implant. But what is worth noting is sometimes, even with these higher than what we'd ideally want thresholds, actually sometimes you can accept them. Why? Because you don't necessarily need to apply such a large safety margin. What do I mean by that? If you've got someone who has non-selective HIS bundle capture, and then as you come down on the output, you end up with myocardial capture, as you can see in the cartoon here. In this case, that myocardial capture below the non-selective threshold gives you a safety buffer for programming. You also sometimes hear that thresholds rise over time. On the whole, actually, from the published data that we've got, they're reasonably stable. There is overall minimal change reported in some of the series. And that's even after AV node ablation, HIS capture threshold can be reported as being stable. And again, here's another case series. That being said, in approximately 5 to 10% of cases, there will need to be a reintervention. And the problem, unfortunately, is we can't readily predict at this stage who these patients will be. This is frequently because of loss of capture, lead displacement, or due to significant rise in threshold. But I think this 5 to 10% figure is something that we should interpret with a little bit of context. And I'm going to spend probably the next 10 minutes talking about capture and sensing issues. Oversensing of inappropriate signals can result in potential inhibition of potentially life-saving pacing. This is a real problem. Now, the HIS lead, although positioned to activate the ventricle, is not usually sited in the ventricle. It's commonly sited in the atrium, and you can see you've got the atrium here, the tricuspid valve here, and the RV going off in that direction. Now, this location with current device sensitivity algorithms could lead to P-wave oversensing, ventricular undersensing, particularly if only a small V signal is seen by the lead, or even HIS potential oversensing if there's a massive HIS potential observed. And you need to know as physicians how to utilize the current devices to mitigate these issues. Because as Harren has said, there are no HIS dedicated algorithms as yet to optimize HIS bundle pacing. That being said, getting the implant right can make things much smoother and avoid the need or reduce the need to have to troubleshoot during follow-up. We've mentioned this, you've seen these figures already today. Try and aim for a position where you are distal enough to be distal to the AV node, distal along the conduction system so that you get a large V sensing. Remember, we're after an A to V ratio where the V signal is at least double your atrial signal, ideally at least 3 times. This will significantly lower your risk of atrial sensing or even of capturing the atrium, and also will potentially be more distal to sites of block. To achieve a more distal site, you've seen this already again. Take advantage, if it's difficult, you're nervous to move the lead, of using a 2-lead technique. Okay? Use your first lead as a marker and place your second lead in a more distal location along the conduction system. Now, in this example, you can see that the two leads are actually quite widely separated. I have to say this example from our institution highlights that actually sometimes only very slight variation in lead position is actually needed to achieve the change in electrogram that you need. At implant, it's also worth making sure that you give optimized amount of slack. Excessive lead slack crossing the tricuspid valve of each heartbeat has been suggested as a possible reason for late rises in threshold, as the valve motion may cause slow damage to the lead. So what you really want, optimized slack so that it doesn't prolapse through the valve, is potentially going to be far less likely to cause you these late rises in thresholds. Now thinking about follow-up. It's very important, as has been stressed by multiple people today, to know the types of capture that a patient has. And that is so that you can program appropriately, so you can actually deliver His bundle pacing and not just high RV septal capture. And this can only be assessed on a 12-lead ECG. If you utilize a single lead ECG, for example, you just use the PSA, I don't think it's good enough. I think if anyone looks at this trace here, single lead ECG, I don't think you can discern the actual changes that are occurring in capture during this trace. But when the 12-lead ECG is used, all relevant transitions can easily be seen. You start off with non-selective capture with reversal of left bundle branch block, then selective capture with reversal, and then selective capture without reversal. Knowing this data can have important implications on how we program the device outputs. Now, if we're struggling to determine if we have His pacing rather than high septal RV pacing, there are a number of maneuvers we can do. I'm not going to dwell on these because you've seen them. It's the 12-lead ECG. It's the extra stimulus testing. It's retrograde conduction testing, looking at your VA time. Your VA time as you transition from non-selective to myocardial capture should be pushed out as you no longer have your high-speed His-Purkinje system to rely on going retrograde. And then the other thing is to look at pattern recognition, as Marek has already shown us. I'll now look at some cases where there can be issues of sensing and also capture with a His lead. So let's start with probably what is the most common thing to observe, which is atrial oversensing. This is probably the most common troubleshooting issue. So here's our first case. Here at the top, we've got our surface ECG, then we've got our atrial channel, and then our His channel. Now, the marker channel here is detecting ventricular sensed events, because due to the location of the lead, the atrial signal is easily detected on the His lead. And so what we're looking at here is that this signal here is actually this. These two are the same, these two are the same. Now, this becomes a problem when there's heart block, because the pacemaker doesn't do what we think as physicians it should do and pace the heart when there are non-conducted beats. The problem is, from the pacemaker's perspective, it's done nothing wrong. It sensed a large enough signal on the ventricular lead and so didn't need to deliver a pacing stimulus. Getting things right to implant can avoid this scenario. Appropriate lead location, you won't get such a large atrial signal. But if the patient is already in the clinic, we need to know how to troubleshoot this. So here's another very similar example of atrial oversensing. You can see here electrograms from the His lead in bipolar configuration. Sensitivity setting of 0.5 millivolts, there is oversensing of that far-field atrial electrogram, and occasionally even the His electrogram. So again, during episodes of AV block, we could have disastrous consequences. So our first approach here to managing oversensing is switching to a unipolar sensing circuit. And this can allow a much bigger R wave to be sensed, which could be safely differentiated from both the atrial electrogram and also the His electrogram, making the device sense in a far safer manner again. Let's have a look at another trace and think about another way that we can manage atrial oversensing. This is a gentleman who had a dual-chamber pacemaker implanted. He had intermittent 2-to-1 block. As his AV block was intermittent, MVP was programmed at a rate of 40 beats a minute. Unfortunately, though, he presented to the clinic the next week not feeling so great. And you can see why. The His lead was inappropriately sensing the atrial signal and therefore not able to notice when ventricular beats were missing, when AV block was present. And here you can see actually there were many oversensing episodes. The device wasn't mode switching to DDD as it should have done. Now, my colleague who saw the patient decided, I think quite rightly, deactivate the MVP. And what they did was they programmed DDD pacing at 60 beats a minute with an optimized AV delay. And 2 weeks later, the symptoms had massively improved, they'd gone away. So in addition to changing pacing configuration, which we did in the first case, this is another approach to managing atrial oversensing. Now, the reason why I put this approach in is MVP is designed to avoid RV pacing because the QRS complexes, as we've heard already, can be ugly, can be bad news. But we're not concerned with non-physiological, horrible-looking QRSs with DDD pacing, with His bundle pacing. So that enables us, instead of being stuck between a rock and a hard place, between RV pacing and pacing avoidance algorithms with long AV delays and dropped beats, His bundle pacing allows us a solution that gives us healthy AV delays and healthy normal QRS complexes. There's more tricks that we can use to deal with atrial oversensing. So here's another example where both atrial sensed and this time atrial paced episodes can be detected in the His lead intermittently. And here you can see the far-field atrial sensed episodes, which could potentially inhibit pacing if AV block occurred. And I've included this example because you'll note that ventricular safety pacing occurs following an atrial sense paced beat. And that's exactly as the algorithm is meant to do. This means that in this situation, encouraging atrial pacing will result in VSP. So that could be atrial preferential pacing as an algorithm. And that will lead to ventricular pacing via the His lead. There is also another way to manage atrial oversensing. And this is similar to what Harren showed you already. In this example, the R wave reported by the device was only 0.8 millivolts. But if you look at the EGM, this is clearly unlikely. It's definitely bigger than 1 square. In fact, this measurement of 0.8 inappropriately reflects the sensed atrial signal, which was measured first, and due to the way that autosensitivity algorithms work, meant that the true R wave was then ignored. In this patient, we changed our sensitivity to avoid inappropriate sensing of the atrial EGM without any further issues. So when thinking about managing atrial oversensing, there are many options. Reposition the lead. It's a good idea at implant, but probably not ideal during follow-up if you can avoid it. Change from bipolar to unipolar sensing, as you've seen. Change the sensitivity to ignore the atrial component. Change from autosensitivity to fixed sensitivity, again, to ignore the atrial components. Or simply program DDD pacing at a faster rate to ensure pacing, as you saw in one of the other cases. The other thing here is you can employ atrial preferential pacing, which then allows ventricular safety pacing to provide you a backup if you really need to. So now let's move away from the atrial oversensing and think about His oversensing itself. You might think during mapping, the bigger the better when it comes to a His signal. This is not always true. Similar to atrial oversensing, a massive His signal can affect sensing and cause potential mischief. But actually, we manage it in the same way as atrial oversensing, for adjusting sensitivity or even sensing polarity. And more often than not, that will result in a better ratio between electrograms. Now, it's possible that if this is an issue immediately after deploying the lead, that actually this could result from your His injury current, as you can see here. And actually, don't move the lead straight away. Wait, as quite often this injury current will resolve within 10, 15 minutes and then won't affect your sensing anymore. And just as we've seen issues of atrial and His oversensing, we can also have issues with ventricular undersensing. Here we have a patient with MVP programmed who has intermittent heart block. You can see here there are frequent PVCs, which are not all detected by the His lead. Although the PVCs that are in the blue circles are sensed, those in the red circles are not, and that is despite a maximum sensitivity of 0.5 volts. Clearly, this ventricular undersensing could be concerning, as could lead to inappropriate pacing and potentially pacing in the vulnerable period on a T wave or something like that. So much like with atrial oversensing, we can consider alternate pacing vectors to deal with this. And you can see here, the true bipolar configuration gives a small R wave, hence why it may be undersensed. Yet using unipolar or a far-field electrogram, for example, using the ring electrode, we generate larger ventricular sensing circuits. Now, although far-field sensing and unipolar sensing can be useful for troubleshooting, it's worth ensuring that if you do program to a larger sensing circuit, that myopotential sensing is not present, which could lead to ventricular lead output inhibition, which is also counterproductive in this situation. Now, the anatomical location, as well as causing sensing issues, can also cause interesting capture responses. These are not common, but things that you should really be aware of. So due to the His bundle's proximity and your lead's proximity to atrial myocardium, atrial capture during His bundle pacing is possible. And as we decrease the pacing output here, we go from capturing the His bundle with very short stim to V time of only 40 milliseconds to atrial capture. And this is proven by the lengthening of the stim to V interval up to 120 milliseconds, which is obviously a typical AV interval. There are three considerations really to make regarding this. One is be aware of this phenomena. Make sure that when you're documenting a threshold, you're actually documenting your His threshold and not an atrial threshold. Make sure that you pace with sufficient output, that you deliver His pacing. And I have to say, when you get this, if you're pacing in a dual chamber pacing mode, because your atrium is going to be refractory because of the way dual chamber pacing modes work, this is actually unlikely to cause any atrial capture when your His lead fires as well. Another element relating to ventricular capture to watch out for is infrahischian block, particularly at rapid heart rates. Here we have someone with symptoms during exercise. At rest, everything looks great on the ECG, one-to-one AV conduction. But with exercise, you can see what the problem is. The sinus node does the appropriate thing, speeds up, but unfortunately, there's AV block present. Now, the His bundle lead, positioned at a distal His Purkinje location, can conduct, as you can see here, up to around 120 beats a minute, which for many, perhaps elderly patients, is more than sufficient. However, with further increases in the paced heart rate, this gentleman was not able to conduct in a one-to-one basis. The infrahischian tissue was refractory at these higher rates. It's rare, but something to bear in mind. And for this reason, there are many labs around the world that do rapid His bundle pacing before they accept a final lead position, just to make sure that this issue is not present. Thinking about the way that we program these patients, we shouldn't really use automatic capture management if the lead is in the RV port. We all know RV capture, RV pacing is binary. There's capture or there's not capture, and there's an immediate evoked response following your pacing stimulus. And detecting an evoked potential after the pacing stimulus is in essence how auto-capture algorithms are designed to work. These evoked potentials, though, are absent in selective His bundle pacing because of that isoelectric interval, that HV delay. And they can sometimes be mistaken in non-selective His bundle pacing. So in this trace at the top here, you can see that we transition from non-selective capture to RV septal only capture at 1 volt, and then total loss of capture at 0.5 volt. Threshold should be reported 1.25 for the His, 0.75 for the RV. And ideally, we'd probably want to set our pacing output 2.5 volts. What does that mean? That means we're at more than 1 volt above the His threshold, and we're double the His threshold. The problem is, if we use the auto threshold algorithm here, it would identify the capture threshold at 0.75 and would then aim to pace only at 1.5 volts. In this example, that's probably not a terrible issue. But in this example, the use of auto-capture algorithms becomes pretty useless. Here we have non-selective capture with a transition to selective capture at 3 volts, which you can see changes the evoked response, and then we have loss of capture at 0.5 volts. In this example, optimal pacing amplitude would probably be around 2 volts, but the auto-threshold testing algorithm here would report the threshold as 3 volts, and then it would aim to program much higher than necessary programmed output, perhaps even 6 volts, which would be disastrous for battery longevity. Now, there is one element of remote monitoring, if you can use remote monitoring with your His bundle pacing, which can be very useful, and one that I would stress that you do look at. If there are observed changes in lead impedance, this should probably prompt in-house review of the pacing thresholds. Unfortunately, we've begun to see that changes in impedance have been associated with these late increases in pacing threshold. And if you can spot that from a change in impedance, that may be able to prevent any significant clinical harm if there is a future loss of capture which may occur. You can perhaps do alternative programming, or you can undertake a lead revision at an early stage. In the future, I hope that improved delivery kit will enable better outcomes at the time of lead deployment, and less troubleshooting will then be needed. But just before I finish, just a reminder, the majority of cases you will do will have great-looking narrow QRS morphology, low capture thresholds, no far-field oversensing issues. I'm going to stop there. Thank you very much. And just to say good luck with your HIS bundle pacing.